If you've been suffering from calcium oxalate kidney stones for any extended period of time, your doctor at some point may have told you that a digestive disorder was at the core. But what digestive disorder, and what role would these kind of things even play in kidney stone formation? If you're curious to know the answers to these questions, stick around for this video. Hi, I'm Joey Weichman, and welcome to Stone Relief. Today's video is going to focus in on kind of dispelling some half-truths and myths that are out there about calcium oxalate kidney stone formation, in particular about digestive disorders. Now, on a week-to-week basis, we talk to a lot of people about their kidney stones, and it never ceases to amaze me that digestive disorders get blamed for kidney stones amongst a whole host of other really inappropriately blamed items. So today we're going to go through and kind of walk through some of the most common digestive disorders, which actually turn out to be not that common at all in terms of the overall population, and how they may be tied to kidney stone formation, in particular calcium oxalate stone formation. And we'll talk about the bottom line of this and if there's any validity to this at all. So the first place we're going to start, we're going to talk about inflammatory bowel disease. This is something that is kind of talked about a lot in the health communities. Upset stomachs, diarrhea, a whole host of digestive disorders are kind of lumped into this, and it really is not well understood. And we're going to kind of piece this together here. So IBD, this is a group of disorders, a bunch of different stuff that is causing chronic inflammation in your gastrointestinal tract. These are things like Crohn's disease, ulcerative colitis, and there's literally a list that is so lengthy that it won't even fit on this board. So these are the major ones that most people are aware of. Now, it's not to be confused with IBS. Now, irritable bowel syndrome has very similar symptoms. This gastric upset, the diarrhea that people most often associate with it, but it is not doing damage to the gastrointestinal tract like IBD disorders are. Now, fortunately, these are pretty rare, and I had mentioned they come up and they're discussed quite a bit. Someone at some point in time, or a doctor has most likely said, oh, you've got IBD, because it's just one of those kind of catch-all scapegoat things, but the actual identified case rate of this is relatively low. It's actually less than 1% of the global population. However, there seems to be some higher numbers here in the US. So it's less than 1% of global, but there's over 3 million individuals in the United States alone that are suffering from this. And when we talk about causes, well, the medical communities, they're confused. It's a mystery, but you and I know better. And if you've been following me for any period of time, this is really tied to diet. And we're going to dive into that more in the next chapter. Okay, so we know that IBD, irritable bowel disease or disorder, is pretty rare. And as such, there's pretty limited data that's available, but it doesn't stop the medical community from blaming this for calcium oxalate kidney stone formation. So, based on the data that is available, a couple things that we can determine. So first and foremost, the data does show that there is a slight increase in urinary oxalate in those people who are suffering from IBD. Now, this is important to note here. This is not an interventional study that is available, meaning there is a control and there's tests that are occurring that are independently controlled and separate. This is observational data, and this is really messy, bad science. This is correlation equals causation type of science, and we all know that that is complete fallacy. So take this with a grain of salt. Now, in the people that have been identified in these studies, people with IBD had urinary oxalate excretion of around 42 milligrams a day. Non-IBD subjects in these studies, around 39 milligrams a day. Not much difference here. And then we also were investigating people who had small bowel resectioning. Now, this could be as a result of maybe it's a weight loss type of thing, or maybe it is try to be a solution to IBD where they just go, oh, we don't know what's causing it, just cut it out. And this causes a whole host of other problems, because when you cut out a portion of your digestive tract, a lot of bad things happen in your kind of hampering your body's ability to deal with oxalate, and then it shows up in our urine, which is why it is higher here in those individuals with small bowel resectioning. It is around 57 milligrams a day. Now, I want to just pause here and point out something that's significant. all of this data here that's here, these are now knocking on the door of primary hyperoxaluria. And PH1 or primary hyperoxaluria is really indicative of over 40 milligrams a day of oxalate excreted. So like not only is this potential population data already kind of a little bit muddy, but it is actually showing that there's some increase in oxalate. So there's something to this. But again, we're going to talk a little bit more about oxalate and its role in a second here. Now, the other thing that it impacts is urine pH. Now, urine pH, we do know when calcium oxalate stones, it does impact crystallization. So the IBD patients were around 5.98 or roughly 6. Non-IBD, again, 6-ish. And then the small bowel resectioning patients were a little bit lower than this, around 5.4. Now, these pHs are pretty acidic, and we know from previous videos that crystallization of calcium oxalate stones really is maximized between 4.5 and 5.5, which again is acidic urine. Now, as we can ascertain from all this stuff, really all that we're taking away when it comes to IBD's role in calcium oxalate kidney stone formation is really it could potentially relate to oxalate excretion, and then it also has to do with urine pH. But we're smart and we've watched previous videos and we know that, well, when it comes to oxalate excretion, just eliminate oxalate from your diet and the problem goes away. And even urine pH, again, becomes a little bit irrelevant if there's no oxalate present. However, if there is oxalate present, you can do things to neutralize your urine. Most of this is driven by diet. There are some alkalizing agents that you can use, but you have to use them cautiously because if you go too far up into that alkaline spectrum over 7, 7.5 on the pH scale, you start to open yourself up for calcium phosphate stones. So now that we've kind of summarized that IBD really probably doesn't really have much of a link. If you change your diet, you eliminate oxalates, this problem pretty much goes away. And honestly, if you clean up your diet, like your IBD problem will go away as well. Now, there's a ton of anecdotal evidence out there with regards to the carnivore diet or an animal-based diet and its resolution of IBD for scores of people. Now, the medical community and the research community is really probably not going to touch this with a 10-foot pole because, again, their goal is to keep you sick and dependent on the system, which is really reliant on pharmaceutical drugs and surgery. So they're not going to do this kind of stuff because they'll find out very quickly that, hey, if I just fix my diet and I start eating species-appropriate foods for us, not ultra-processed foods jammed with sugar, well, guess what happens? A lot of these issues go away. And in the next chapter, we're going to talk about another digestive disorder that is commonly blamed for those calcium oxalate stones.
Just a reminder, this information is available in written form on our website. Find the link below in the description.
So, now that we've got IBD out of the way, or inflammatory bowel disease, let's talk about chronic pancreatitis, because this is another one that comes up quite a bit in the people that we talk to. So chronic pancreatitis is an inflammatory disorder of the pancreas. And basically what's happening is there's damage that is going to be occurring to the exocrine and the endocrine system that is in the pancreas. These are the parenchyma, the functional portions of the pancreas. And the exocrine system is really responsible for digestion, and we'll talk about more about that digestion aspect in the next chapter. And the endocrine system is hormones. So this is like insulin signaling and all different sorts of body processes that are impacted by this. So fortunately, this is, again, another one of those things that is relatively rare. Less than 1% of the US population. I could not find reliable data as far as the global population that I trusted, but less than 1% of the US population, which is around 80,000 to 100,000 people a year who are suffering from this. Average onset of this is around 62 years of age, which could have to do with its low level of reporting, because most people when they reach that age are like, just stuff is breaking down and it is what it is, and they just kind of accept their fate. Whereas more of the younger generations they're trying to solve this issue. Not for everybody, obviously, but on a whole. And traditionally, or most commonly, this is a problem that is caused by alcohol. And I don't want to call it alcohol abuse, but definitely alcohol abuse could potentially play a role in this. But curiously enough, alcoholics are not actually part of this population. They're a very small percentage of the chronic pancreatitis population. It's actually less than 10% of the population, whereas people who are casually consuming alcohol have more of an issue. And really the studies have identified for men, if you're consuming more than 2 alcoholic drinks a day, this could be beers or hard liquor drinks or mixers or whatever it might be, as a whole, this is identified as a risk factor for chronic pancreatitis in women greater than 1 drink a day. Again, this is just body size differences predominantly that are driving these differences between 1 drink or 2 drinks per day based on sex. So we're going to talk about in the next chapter how this ties potentially to kidney stone risk for calcium oxalate stones. Okay, so very similarly to IBD, there's not much data when it comes to chronic pancreatitis and it's linked to kidney stones. But again, comes up all the time. And again, I think it's more along the lines of just doctors being uncertain as far as what the tie is for these people who are suffering from recurrent calcium oxalate kidney stones. So it's like, oh, maybe it's this. I read this in this paper. Not really founded in actual science. So very limited data. There is no study that is directly pointing. However, there is an indirect relationship. And that indirect relationship deals with oxalate absorption. Now, primarily this is fat malabsorption. It's the driver for this. And I've done my best here to kind of break down this relatively complicated process in as simple terms as I possibly can to help you understand if you're suffering from chronic pancreatitis, why you might be suffering from recurrent calcium oxalate kidney stones. So fat malabsorption, driver, got it. Unabsorbed bile acids and fatty acids are part of this fat malabsorption, or malabsorption meaning is you're struggling or there's an insufficient absorption of fat, is binding with calcium in the gut. Now, binding with calcium, we're pretty sensitive to that because we know oxalate binds with calcium. We're like, oh my God, what's happening? But in this instance, it's actually not necessarily a bad thing, but it leads to problems. So when we have calcium binding with other things than oxalate in the gut, this leads to decreased availability of calcium to bind with oxalate. Now, oxalate and calcium binding in the gut is not a perfect science. We have a whole entire video that's dedicated to talking about this, and this is a very commonly misunderstood thing. Most urologists and doctors will say, well, just take more calcium if you're going to be eating oxalate, and it's problematic. Yes, more calcium that you do consume, the lower level of oxalate that you do excrete. However, these things are not tied together intrinsically. So your oxalate intake does not equal your oxalate output. These things, your body does not know how to handle it. It gets shuffled all over the place, joints, glands, in our kidneys, a whole host of things. So the absorption rate of these two things are not equal. So even though there's less calcium to bind in the gut with oxalate, this is really not at the root, as we talked about with IBD, and we'll center in again here in a second. Now, so that there's less calcium, again, this means that there's more opportunity for oxalate, which is unbound, meaning it's not bound to calcium, to free float around the body, to mingle with other things and form and crystallize. Now, that increased oxalate is also going to lead to an increase in our oxalate excretion in our urine, which is measured by a 24-hour urine test. And when this happens and we're excreting more oxalate, our stone risk increases because it is then free to bind with those calcium ions in our kidney. And as we know, they're magnetically charged to each other. One's positive, one's negative, and they pop together when they are supersaturated, meaning there are excess ions that are available that have not been dissolved. Now, remember, and again, this is tying back to this fact, this is not a problem if you don't eat oxalate. No oxalate, no stone risk. And if you're forming calcium oxalate kidney stones, you're really lacking the metabolic machinery in order to process oxalate. This is the root of a problem. It's not about a chronic pancreatitis problem or an IBD problem or any other type of thing to blame. At the root, you do not have the genetic or metabolic machinery in order to process oxalate appropriately like the other 80 to 85% of the population whose evolutionary path did develop a better system, not perfect, but a better system to manage oxalate, whereas on our system side, we get kidney stones. So if you eliminate oxalate from your diet, a lot of things change. You'll probably eliminate chronic pancreatitis problems and IBD, and you'll also stop your kidney stones. But I understand that this is not always an easy thing because there's a lot of really conflicting information out there. Your doctor is probably going to tell you one thing. You're going to read another thing in a book or listen to another thing in a podcast. This is an area where getting a coach can help significantly. Now, we offer kidney stone specific coaching on our website, but there are no shortage of individuals out there who would be happy to help you clean up your diet, eliminate the oxalates, and really truly start thriving. So if you're really dedicated to eliminating your recurrent calcium oxalate kidney stones, get a coach, or just at the baseline, cut out oxalates and try to take steps to figure out the rest on your own, because it will make a major difference in the overall quality of your life. Visit our website if you'd like to join a community of people learning to manage their kidney stones naturally. See you in the next video.